Can progress, please.
Okay. Okay, good afternoon, everyone. So I hope I am audible.
Yes, you are very clear.
Okay, so we'll be starting with the picture test, and for the purpose of introducing to us the concept of picture test, it's important for us to just explain to us certain things that we need to understand before we go to the pictures proper and we attempt the questions under them. So one thing about picture test that we need to understand is that understanding what the picture is trying to depict is a fundamental basis for you to know what to answer in terms of the question that will follow up. If you don't know what the picture is, you are likely not to get right what the questions that will be asked under it will be. So it's important for us to first of all decipher what the picture is and what questions follow before you start attempting it. Sometimes the pictures might not be too clear. A way of getting to know sometimes what the pictures are talking about is by looking at the questions. You might see a picture of a peripheral blood film depicting some cells, some blood cells. You are not sure, are they talking about sickle cell? Are they talking about vitamin B12 deficiency or folic acid deficiency, or what exactly is the question? So if you look at the question, you now see that artesunate is a choice of treatment. Oh, that way you know that, okay, they're asking me to look at ring form of Plasmodium falciparum in the peripheral blood film of this patient. So those are the kind of things that can help us to understand what the picture is telling us if the picture is not so clear. Then when we attempt questions, try to know, is it true or false they want us to answer? Is it 1 in 5 that they want us to choose? Regardless of whichever it is, once you take each question in isolation with related to the picture, and that is where we can get to know what answer is appropriate for the question that is being projected. Now, I wouldn't know how many questions you'll be given in this exam, but time is another factor you need to put into consideration, because they might project a picture and just say maybe like 30 seconds or 1 minute is the time allotted to the picture. So if you miss out during the allotted time, you are unable to complete that particular picture, you might just have to skip over that particular one. But one needs to be cautious of the fact that once you miss over a particular question, ensure you skip that question in your answer sheet. Ensure you skip the question in your answer sheet such that you don't carry over, so that you don't carry over a question to another question. I mean, the question you were unable to answer question 5 before the picture was changed. Answer sheet while you go to question 6, you just be carrying over the question for the answers for question 6 to question 5, question 7 to question 6, and of course you know that's a disaster at the end of the day. So once you miss out a question because you are unable to complete it because of time, just move ahead and skip that particular question. Take note of it. If you are able to recap after the whole exam, you come back to it. But it's important that you skip that particular aspect in your question too. Now, Dr. Bashir, can you go to the first questions? Going to the questions proper now. So this question is showing us the picture of a child with a cleft. Should I be calling it now? I don't know. Dr. Bashir, what part?
Your network is shaky. We can't hear you properly.
Okay, my network, I was asking that, should we make it an interactive session, or I should just go ahead because of time?
Yes, you can go ahead because of time.
Because of
The time they will just
okay.
keep quiet. Don't mind them.
Okay, because trying to call them one by one might take a lot of time, won't be able to move fast. Okay, so this particular picture is showing us a child with a defect in the buccal cavity, but the defect the child is having is not restricted to the lip. We can see up to the margin of the base of the nostrils that the palate that is lying below the nostrils is also defective and is not well formed. So from this picture, it is said that identify the image. This particular picture was prepared as a single answer question. So you have to select the best of the 5 options that is given. So here A is saying cleft lip. Yes, there's cleft lip there, but it goes beyond cleft lip. B is cleft palate. Cleft palate is also there, but it goes beyond cleft palate only. All of the above. So D is saying cleft lip and palate. Yeah, both of them is what we can see here. We can see that the lip is cleft and the palate is also cleft. So, and none of the above. So some of the questions that could also arise from this kind of picture is they could say, what are the immediate problems this child will encounter? Of course, problem related to feeding is a major one. This category of children will not be able to coordinate sucking very well. The airway is so much linked with the buccal cavity. So feeds could be getting into the airway, and there could be compromise of the airway, the frequent respiratory tract infection. So these are the kind of problem you anticipate. So they could also ask that what is the modality of feeding and all those things that could come with this kind of presentation. So we talk about the use of obturator spoon. Obturator spoon is a way of feeding this baby such that the feeds are delivered directly into the oropharynx, and getting into the airway is usually prevented with this kind of spoon. Next slide, please. Okay, so question 2 is telling us about this patient. The question says, this patient is likely to have which of the following? A says karyotype 45XO. B says rudimentary ovaries. C is amenorrhea. D is web neck. E is all of the above. So looking at this patient, this is a classical picture of a patient of a patient that has monosomy. Monosomy and the prototypical manifestation of monosomy is Turner syndrome. The karyotype of a patient with Turner syndrome is 45XO because there is one absent sex chromosome. So we have it as 47XO. So for this category of patients, they have all these manifestations: rudimentary ovaries, amenorrhea, web neck. Some of them we have those COVID developing into cancers later in life and the likes. So the answer to this particular question is all of the above. The karyotype is correct. They have rudimentary ovaries, amenorrhea. They don't have, their mesis does not come, and web neck. Yeah, if you look at the neck closely, you see that it is web. They also have what we can see in the picture here is wide spaced nipple. Is one of the manifestations of monosomy Turner syndrome. They have wide spaced nipple. So all these are all manifestations of Turner syndrome. So the answer for this one is all of the above, E. The next question, Dr. Rashid. Okay, so spot diagnosis, they're asking us a question here. Is this gastroschisis? Is this omphalocele? Is this enterocutaneous fistula? Or is none of the above? So usually it's just between two of them here, gastroschisis and omphalocele. It's definitely not enterocutaneous fistula. So, and it's one of the above, so it's not none of the above. So between gastroschisis and omphalocele, this viscera that is outside the abdominal cavity, this patient has a membrane covering it. When you see a membrane covering a viscera in a newborn, think of omphalocele. But when you have the viscera that is not being covered, by a membrane, that's gastroschisis. So for gastroschisis, we have usually it arises from lateral to the umbilical. So that's another way of depicting gastroschisis from omphallosis. For omphallosis, it usually arises from the umbilicus and it's covered with the membrane. So we keep that in mind. So for this particular picture, the answer is omphallosis. Omphallosis is the diagnosis, is the answer for this. Next picture, please. Okay, identify the illustrated image: meningomyelocele, encephalocele, sarcoplastia, teratoma, lipoma, none of the above. So the image that is shown in this picture is for meningomyelocele, the defect is usually in the lumbosacral region for most of patients. It could manifest as occulta or cystica. Cystica is the one that is covered, occulta is the one that is exposed. There's a defect in that vertebra, that lumbar vertebra, in that lumbar region, and as a result of that, you see the spinal cord protruding out of that, together with the pia mater, that is the arachnoid matters and the dura mater and all these things, all of them protruding out of the defect. And for some, that is the hidden type. You could have it as just some dimple in the region, discoloration in the region, or tuft of hair in that region of the lumbar region for patients with myelomeningocele. However, for encephalocele, it's just another form of dystrophism. All these defects, myelomeningocele, encephalocele, they are dystrophism. They have to do with defects in the formation of the vertebra. So for encephalocele, it's similar to lumbar meningomyelocele, but it is more at the cephalic, the cervical region of the spine, such that the area that is affected is usually the cerebellum that protrudes into the defect that is formed in the cervical region of the vertebra. So you have encephalocele in such cases. So it's a form of dystrophism. However, for sarcoplastia teratoma, is one of the types of yolk sac tumors that we have, such that it arises from the sarcoplastia area, and it's one of the malignant tumors that we have in children. It could also arise as a yolk sac tumor in other parts of the body, but the commonest site where you see it is the sarcoplastia area. So when you see a mass protruding from this area, from the sarcococcyx area of a child like this, you understand that sarcoplastia teratoma. Lipoma is more of a benign tumor, and it's usually a fat accumulation in some part of the body. So it could be anywhere on the body, but it's just a benign fat accumulation that can be excised. Next question, please. Next question, Dr. Bashir. So the next question here. Yes, this is question 5. So which of the following is true regarding this condition? It is more commonly seen among adolescents and elderly. It is commonly caused by excess vitamin D in the body. Treatment includes daily vitamin D supplementation. Vitamin D deficiency is the only etiology factor. So what is this that is depicted? This is genovalgum. The knowledge, the way of understanding this is that when you have the knees together, not knees, that is gum. You kind of say that the knees are gumming together. So that's genovalgum. While when you have the bow leg, you have it is the opposite, varus, genovarus. So it is commonly seen among adolescents and elderly. This is not true. The fact that they are using an adolescent picture here is just a way of misleading us. This is commonly seen. This particular patient could probably have had this from childhood and it progressed into adolescent or adulthood. So it's commoner in children, and that is because that's a age at which that's the time that the bone formation and development of different parts of the body takes place. It is commonly caused by excess vitamin D in the body. Rather, it's a reverse, is an opposite of the situation. Deficiency of vitamin D and calcium is what causes this defect. All this comes under the manifestation of rickets. When you have patients with rickets, they have a wide array of manifestations, including the manifestations of the appendages. That's the names. I will go back to that just to after answering this question. Treatment includes daily vitamin D supplementation. Yes, you give vitamin D every day, and that's the correct answer. Vitamin D deficiency is the only etiologic factor. That is not true. Vitamin D deficiency, calcium deficiency, and a combination of the two are the possibilities that could actually cause this manifestation. And apart from nutritional rickets, there are other causes. Cancers, metabolic derangements could also result in deficiency of these manifestations of situations like this. So for rickets, the manifestations vary depending on the part of the body each child is manifesting with. For the what we are seeing is the manifestation of the appendages, and it could be like this: knock knees, which is referred to as genovalgum, or genovarus, bow leg, or windswept deformity, whereby one of the knees is coming to the midline, the other one is going out from the midline. So that's the manifestation of the appendages. Apart from that, we could have defects in manifestations of the head, which could be in form of caput quadratus, a box-shaped head. You could have a box-shaped head. Then the skull bone could be so brittle that you can indent it, and they call that the ping pong sign. Ping pong sign. That's due to the brittleness of the skull bone. So, and there could also, you could have features in the ribs, which could manifest as rachitic rosary because of the swelling of the metaphysis of long bones. That's another thing we see in them. Swelling of metaphysis of long bones. So when the metaphysis of these long bones swell, you could see them as kind of linear swelling along the costochondral junction of all the ribs. So it appears like beads. So they call it rachitic rosary. Rosary from beads. So they call it rachitic rosary. So also you could have what you call Harrison sulcus. Harrison sulcus is when there is indentation along the costal margin, because of the brittleness of those bones. The diaphragm will contract during respiration and pull in those bones, giving us a kind of sulcus. Yeah, so that's part of the manifestations we see. They are also prone to frequent respiratory tract infection and the like. So it's part of the things we see in them. So that's how far we can go on rickets. So just some additional information is what I can give you. So the next question is this. All of the following are associated with the condition, except, yes, what we can see here is pectus excavatum. Pectus excavatum. Yes, you can see this in Marfan syndrome. Marfan syndrome is a condition whereby you have elongation of the body. It's one of the collagen vascular diseases, and there could be all the long bones could be so elongated, and the bones could be brittle, giving this kind of manifestation of ricket. We've said a lot about ricket, and this is one of the things you could actually see in ricket. And manifestations like this compromise the airway, making them prone to frequent respiratory tract infections. Scoliosis, bony defect is also one of these that we see in them. So all of these above things are all features that could align with pectus excavatum. So none of the above is not true in this case. Next question, please. So the next question, question 7, yes. So this is a picture of a boy with a jaw swelling. So it is a non-Hodgkin's lymphoma. It has a male to female ratio of 2:1, of course, within the age bracket of 3 to 15, and it is a metastatic tumor. It is multicentric in nature. So they are trying to tell us that which one is not true among all these. Which one is not true among all these questions? All are true except, so non-Hodgkin's lymphoma, yes, this is bucket lymphoma. When you see jaw mass, think of bucket. This is bucket lymphoma, and usually for bucket lymphoma, you have a male preponderance, 2:1 as depicted in the option. And also, it is important to note that for bucket lymphoma, the age range is more between like 5 to 15 years. So occasionally, you could see some children presenting at a little less than 5 years, but the C might still be acceptable as an age of presentation for children with bucket lymphoma. It is a metastatic tumor. Bucket lymphoma is not metastatic, but it has specific systems where it can manifest. And when you see bucket lymphoma, think of 3 sites. 3 sites. And that is jaw, abdomen, and the CNS. The jaw, abdomen, and CNS. So bucket lymphoma could arise from the jaw, it could involve the abdomen, and when it involves the abdomen, organs like the kidneys, ovaries, testes are the things you think of where it's originating from. And CNS bucket is another form of bucket lymphoma that could be devastating. It is multicentric in nature. Yeah, that it is multicentric in terms of the pathology. I mean the analysis of the pathology in terms of histology manifestation when you analyze it. So the next picture, of course, it is a chemosensitive. Some things we need to know about bucket lymphoma is that it is chemosensitive, and it can be treated with medications rather than surgery. So in the management of this condition, the following are the likely complications. They say tumor lysis syndrome, air loss, renal injury, nausea and vomiting, none of the above. Of course, when you give chemotherapy, the complications of chemotherapy are all the things that have been highlighted in this option. The less likely complication is, so the answer to that is none of the above. The next picture is which of the following is not a type of displayed image. So as we discussed earlier, dysraphism, this is a spinal bifida, and it could be cystical and occult as we talked about. So all of the above is the answer to this particular picture. So the next question is which of the following is not a likely feature? So we should know the fascia of Down syndrome. This picture that is being shown to us is Down syndrome. So like what I told us at the initial, in the introduction to the picture test, sometimes if you are not sure of what they are trying to tell you, you see a boy, handsome looking boy with good haircuts, you are wondering what they want me to see in this one. You can't appreciate the fascia of the Down syndrome. Just look at the options and you see mental retardation, short and broad neck, okay, simian quiz, hypertonia, low settings, okay, they are telling me about a particular syndrome. And something will come to my own, they are telling me about Down syndrome. Those are the ways of, because one might look at this picture and say, I don't understand what they want me to see in this fine looking or handsome looking boy. They are asking me to look at. So you now look at the options to get your answer for this. So when you see mental retardation, short and broad neck, yes. Simian quiz, yes. Hypertonia, never. Low set, yes, true. So usually for Down syndrome, they have, if you ask the question that what what's the commonest manifestation or commonest feature you see in patients with Down syndrome? You talk about mental retardation and hypotonia. Mental retardation and hypotonia. And if you ask you to pick one, say it is mental retardation. They always have mental retardation, and they almost always have hypotonia. So the two commonest manifestations of Down syndrome is hypotonia and mental retardation. So the level of mental retardation is now what differs from child to child. So other things are these things we are seeing here. Simian quiz, low set years, flattened nasal beach, hyperthyroidism, and Sander gap and the likes. So then, of course, some other things, Down syndrome patients we have, virtually all their systems are affected in one way or the other. Talk about the hematologic system, they are prone to acute leukemia, respiratory tract, they have frequent respiratory tract infection, they are prone to adenoidal hypertrophy. Some of them will have heart defects in terms of the cardiovascular system, and they could have things like ventricular septal defect. But the commonest heart defect, if they wake you up from sleep and they ask what is the commonest heart defect that you see in children with Down syndrome, is ABCD, atrioventricular canal defect. That's the commonest defect that you see in children with Down syndrome. So talk about that. And then abdomen, they tend to have duodenal atresia, then CNS, they have atlantoaxial dislocation. So virtually all the systems are affected in one way or the other. So if you are asked about the manifestations of patients with Down syndrome, you think in that line, each system and telling we examine about the manifestations. Next slide, please. So all the following are true, except, they said the demonstrated sign is sun-setting appearance, sun-setting sign. The likely diagnosis is hydrocephalus. Irritability, poor feeding, vomiting are some symptoms that are seen in the infant. Medical management is the mainstay, none of the above. So for this, we are thinking of hydrocephalus. Yes, for hydrocephalus, what you see here is what we call craniofacial disproportion in favor of the cranium. So for patients with craniofacial disproportion, they have this compensatory downward gazing of the eye, so giving a sun-setting appearance, as if the sun is going down at the time of twilight. So you have it as a sun-setting appearance. So this sign is what is depicted here. So the likely diagnosis is hydrocephalus. Yes, true, it's possibly hydrocephalus. Irritability, poor feeding, vomiting, and some of the symptoms seen in children. Yes, in such children, there could be so much pressure in the head, such that the patients will have vomiting, poor suck, poor feeding, irritability, and all resulting from this intracranial pressure. So then the medical management is the mainstay. This is false. What we need to use for this child is surgical intervention. In fact, when the surgery cannot be done immediately, ventricular tap is something that is done to relieve the pressure from time to time. Yeah, even though some medications can be given to reduce the CSF that has accumulated there, like acetazolamide and the like, they are usually not very efficacious compared to the surgical intervention. And when the surgery cannot be done immediately, ventricular tap or external ventricular drain are interventions that will be done to ensure that there is flow of, there is reduction in the pressure as a result of the accumulation of CSF in the vein. Next slide, please. So, which is not true. It can also be present. So, what they are showing us here is cat-eye reflex. Cat-eye reflex. The question says which of the following is not true. It can also present with redness and swelling of the eyes. Yes, some of them could have redness and swelling of the eye when they are coming at an advanced stage. At an advanced stage, when there's proptosis and there's chemosis, when it has gone beyond the retina and it has gone to involve the extraocular periobital layer, extraocular muscles, and the likes. So The displayed image is the classical presentation. Yes, most children will have this initial classical presentation. And the third one is that it can be familiar or sporadic. Yes, some of them are familiar, while some are sporadic. You don't have family history, and they still come down with it. For those that are familiar, it could be due to inheritance of autosomal genes and the sex-related genes. While the sporadic will just occur regardless of the family history of such patients. It's a rare primary malignant intraocular tumor. Well, it's not very rare like that. In fact, presently it appears to be the commonest childhood cancer that we see around, but it's an intraocular tumor. It could, however, involve the extraocular muscles and the like. It becomes orbital. So, but it's primarily intraocular, but not rare as it seems to be. So, next slide. So this is a picture of a child with distended abdomen. Sometimes they just want to assess what are the things you can see in this child. Looking at this child, the child has got a distended abdomen. I can see prominent anterior abdominal wall veins. I can see everted umbilicus. I can see prominent bones, thin extremities, puffy face, and the likes. So those are the kind of signs that can ask you to look at in the picture and make something out of it. So the question asks, which is not likely to cause this? Nephrotic syndrome, liver cirrhosis, malnutrition, they are all possible causes of this picture we are seeing. Because nephrotic syndrome will lead to excessive loss of protein, accumulation of fluid in the body to cause edema, ascites as depicted in this child. Of course, this kind of child has massive ascites. And for massive ascites, the sign to demonstrate is what you call the sign to demonstrate massive ascites. Fluid is fluid. For moderate ascites, usually we talk about shifting dullness, and for mild ascites, we talk about Bordeaux sign. So for this kind of ascites that is massive, we talk about fluid to demonstrate it. So it's the massive ascites. Nephrotic syndrome can cause it when there's excessive loss of protein and there's edema. The second one is liver cirrhosis. Liver cirrhosis also has to do with defective metabolism and synthesis of amino acid to form protein. So as a result of that, this child could also be deficient in proteins that could be responsible to maintain oncotic pressure, causing edema. And the last one is malnutrition. Of course, when you say malnutrition, we are talking about protein energy malnutrition. The child is deficient in proteins that could help to maintain the body oncotic pressure. So the child could develop edema like this. And also abdominal distensions like this for malnutrition could result from kwashiorkor, which would have, in which children will have hepatomegaly as the manifestation of it too. So the answer for this is D, none of the above. So all of them are likely to cause it. Next slide. All of the following are true about this condition, except it can occur as a result of maternal gonococcal infection. That's very true. This, what is shown here, is called ophthalmia neonatorum. That's correct. It does not require any form of treatment. That's not correct. You need to treat. Failure to treat could lead to widespread sepsis, especially for children, neonates, because they can't localize the infection. And when they can't localize the infection, it spreads to every other part of the body and it becomes a big problem. So it does not require any form of treatment. That is false. That is the one that is not true among the answers. So the next picture, please. So what is depicted in this picture is what we call cystic hygroma. Cystic hygroma is a cystic swelling that results from a defect in the formation of the formation of the pharyngeal arc, usually at about the 5th, 6th week. No, sorry, about the 2nd trimester of development, when you have the development of pharyngeal arc and the likes. So when this is not well formed, there will be some cyst, residual cyst that might be present at birth. So it manifests with like this one. It's called cystic hygroma. Yes, it is cystic. Because it is cystic, it will transilluminate. It is not attached to the skin. It could have a globular appearance. So the answer to this is that it is attached to the skin. So the one that is not of this condition is that it is attached to the skin. That's C. So it is usually not attached to the skin because it's cystic and it is a cyst that is underlying the skin. Next slide, please. So this is telling us a picture. When you see hyperinflated pulmonary oligemia like this, when you see pulmonary oligemia, that is poor pulmonary vascular markings that are seen in the lung fields, is usually due to a condition that causes decreased blood flow to the lungs. And usually when you see a condition causing decreased blood flow, think of a heart condition that will do that. And that is tetralogy of Fallot. Even if you are not sure what the diagnosis is. Sorry, excuse me. So if you are not sure what the diagnosis is, the questions that are followed will help us to realize what the diagnosis is. We have in this picture, it is a cyanotic heart disease. Yes, that's tetralogy of Fallot is a cyanotic heart disease. Third spells are characteristic. Yes, third spells are characteristics of tetralogy of Fallot. Left ventricular hypertrophy is a component. That is not true. It is more of right ventricular hypertrophy. It has 4 components. It has infundibular stenosis, right ventricular hypertrophy, ventricular septal defect, and overriding aorta. These are the 4 things. And usually, before you understand it from the fact that the pulmonary or the infundibular stenosis causes the other things. When there's infundibular stenosis, there's a lot of pressure preventing blood flow to the lungs. So as a result of that, the right ventricle is doing a lot of work and it becomes hypertrophied. When it becomes hypertrophied, it extends beyond this natural margin. So when it extends beyond the natural margin, the aorta overrides it in that instant. And when the aorta overrides it, then what we have is that the ventricular septal defect, there will be a defect that is created from that overriding aorta. So left ventricular hypertrophy is a component. It is not a component. So this one is the wrong one of the option. Knee chest position improves stats. Yes, it helps to increase systemic vascular resistance and helps to take more blood back to the lungs. Helps to increase pressure in the systemic circulation to increase blood flow to the lungs, thereby improving oxygenation. So which of the following is not true regarding this condition? What you can see here, the next picture, Dr. Bashir, please. So this picture says that which of the following is not true regarding this condition? The picture we can see is the picture of a throat of a child. And slightly hyperactive exudates are on the surface of the tonsils. So, yeah, even though viral causes are the most common cause of acute tonsillopharyngitis, but it's written here that group A beta hemolytic streptococcus is the commonest causative organism, maybe the commonest bacteria. Maybe you could say it's the commonest bacteria, but it's definitely a major cause of acute tonsilopharyngitis. Glomerulonephritis is a possible complication. Yes, they could have glomerulonephritis. And glomerulonephritis could also, apart from glomerulonephritis, another thing that could occur is acute rheumatic fever as a complication of post-group A beta hemolytic streptococcus infection. So let's take note of this. So fever, malaria, halitosis are some features. Yes, all these are seen. Tonsillectomy is indicated for all cases. We don't just go and do tonsillectomy. So the treatment is use of antibiotics when you have whitish exudate, inflammation, and features suggestive of pyogenic infection. You give antibiotics as appropriate, and you do some oral toileting as required to eliminate symptoms like halitosis and the likes. You don't just do tonsillectomy. You may have to do adenotonsillectomy when you start having features suggestive of adenoidal hypertrophy and there's obstruction to the airway, which is now impeding the growth of the child. So that's when you talk about doing adenotonsillectomy. So that's that on that. Next slide, please. Okay. So a 12-hour-old neonate is brought in by the mother with complaint of abdominal distension and non-bilious vomiting. An abdominal X-ray of the patient is displayed. What is the most likely diagnosis? What is the most likely diagnosis? So, of course, whatever this is, it is something that is causing upper GI obstruction. In fact, the picture we are seeing here is the classical double bubble sign. Double bubble sign. We have one bubble just below the diaphragm in the area of the stomach, and the other bubble at the right flank of the image that is shown. That those lucency area are the two bubbles. So this is double bubble sign, and double bubble sign is usually seen in duodenal atresia. So duodenal atresia is not part of the options here. So, and it's not, it's definitely none of the above is the answer we have that is most appropriate for this question. Pyloric stenosis does not occur as early as this. Pyloric stenosis usually occurs at about 6 weeks of life when the child starts presenting with projectile vomiting. And hypochloremic metabolic alkalosis is the picture that is seen when you do X-ray and things like that. Volvulus, yes, we could have obstruction of volvulus, but the X-ray is not what we see in this situation. Annular pancreas, usually not a manifestation with abdominal distension and vomiting. So, and Hirschsprung disease. For Hirschsprung disease, it is usually a problem about delayed passage of meconium. The child might not even vomit, but there could be abdominal distension. They might not vomit because the obstruction is down, and the abdomen might still be able to take in some meals before it gets to the level of vomiting. So it's more of abdominal distension and delayed passage of meconium at the presentation you will see. And of course, when you do X-ray, it's not this double bubble sign you will see. What you are likely to see is a gaslessness in the pelvic region and maybe some air fluid levels in the proximal aspect of the intestine. Next slide, please. So this is a well circumscribed lesion on the scalp of the young boy. Is a pruritic fungal infection? Yes, that could be true. Wood lamp examination is recommended. Of course, when you see this kind of lesion on the scalp of the child, you want to think of fungal infection and you want to do wood lamp and slit lamp examination. Topical antifungal alone is ineffective. Yeah, usually fungal infection are usually very difficult to treat, and one needs to go systemic as well as topical for it to have a quick and effective response. It is called tinea corporis. Tinea corporis is when you have fungal infection involving the body, but when you have fungal infection involving the scalp, we call it tinea capitis. tinea capitis. And all of the above is definitely not true. So the one that is wrong in all of this is the D, which is this is tinea corporis. It is tinea capitis and not tinea corporis. Next question, please. So the next question, next slide. So looking at this slide, it is said that pallor, jaundice, hepatomegaly are common signs. You still don't understand what the slide is telling you. Diagnosis can be made with hemoglobin electrophoresis. Oh, something now comes to mind. They now tell you about hand and foot syndrome occurs in all ages. They've already hit it on the head for you with that. So you know that they are talking about, you now go back to the slide, you now see those spindle-shaped structures, those single spindle-shaped, sickle-shaped structures on the slide. So you definitely know that they are talking about sickle cell disease. So for sickle cell disease, pallor, jaundice, and hepatomegaly are common signs. Sure, they do have all of these three. Diagnosis can be made with hemoglobin electrophoresis. Yes, hemoglobin electrophoresis is used to establish what the diagnosis of sickle cell disease. Hand and foot syndrome occurs in all ages. Hand and foot syndrome does not occur in all ages. It's a common manifestation in infants shortly after the disappearance of fetal hemoglobin after 6 months of life. Most babies with severe form of sickle cell disease, they start manifesting features of acute VOC, vaso-occlusive crisis. And the commonest VOC that infants will manifest is the hand and foot syndrome. And paludrin and folic acid are routine drugs, yes. Paludrin to prevent malaria, prophylaxis for malaria, and folic acid, which helps to maintain the PCB at a comfortable level for them. So those are the answers to the options, to the questions asked. The next slide, please. So the condition is called genovalgus. So we talked about this. When you say valgus, so it is when the knees come together, we talk about genovalgus. So that X-ray findings are cupping, wine glass appearance. Some people call it champagne glass appearance. So for all of this, there are features you see in the long bones of children with rickets. So they have cupping and splaying of the long bones, and they have the appearance of champagne glass or wine glass appearance. The features of this condition is aseptic arthritis. The differentials of this condition is not septic arthritis. So, and the recommended daily allowance of vitamin D is beyond this, and it's about usually about 600 to 800 IU per day. Next slide, please. The instrument that is shown is a Soluset. A Soluset is like a burette that is used to quantify fluid for children with small size. It is an intravenous giving set. That's correct. Hello?
Hello, we can hear you.
Okay, yeah. So it is an intravenous fluid giving set. So, and it is what we call a Soluset.
I'm saying slide 21.
Yeah, we want slide 22, Dr. Bashir. Okay, so this is a Soluset. So 80 drops make 1 ml. This is false. 60 drops of Soluset makes 1 ml. And also for us to note that the adult fluid giving set is 20 drops. So the Soluset is 3 times the adult fluid giving set. So you need 60 drops to get 1 ml for Soluset, while 20 drops to get 1 ml for adult fluid giving set. Then for blood, because of the viscosity and all that, you need 15 drops to get 1 ml for blood. So that's that and that. So next slide. So interpret the following biochemical results. So you are telling us that biochemical abnormality that is shown here is hyperkalemia. Hyperkalemia. Yes, there's hyperkalemia here, it's 7.0. Usually you expect an upper cutoff of like 5.0 millimoles per liter. So you have hyperkalemia truly in this picture. ECG findings is that of a tall tented P waves. Rather, for hyperkalemia, what you will see is the tall T waves. Tall T waves is what you will see. Exothermia will most likely kill the patient. That is not true. What will most likely kill the patient early is the hyperkalemia. Exothermia, even for patients with chronic kidney disease, they can still tolerate very high level of urea, and usually when it even gets to a very high level, there are other manifestations that will come before you start talking about death for urea, excessive urea level. But very slight increase in potassium can be fatal. It can be fatal. So it's usually very important that we take note of that. Calcium sandals is used for treatment. Calcium sandals is not used for treatment. When we have hyperkalemia, what we use calcium for, and it is not calcium sandals. Calcium sandals is oral form of calcium supplement. They sometimes give it to pregnant women during antenatal visits. But calcium gluconate that we give is the one that is used to stabilize the heart following a result of hyperkalemia. You give calcium gluconate to counter the effect of potassium on the heart. Hyperkalemia can cause cardiac arrest in diastole. Cardiac arrest in diastole. So in order for that not to occur, you give calcium to stabilize the effect of potassium on the heart. Then correction can be done with different agents, like sodium bicarbonate can drive in potassium into the cells. You can also give glucose insulin infusion, for which insulin will drive in glucose into the cells and at the same time drive in potassium. Also, nebulization with salbutamol. Nebulization with salbutamol. Excuse me. So by nebulizing, you also drive in potassium into the cells. Iron
Dr. Mahfouz, we can't hear you. Hello.
Am I audible?
Okay, now you are audible. Before you, are we at 24?
Yeah, I'm still trying to round up on 23. So I was saying that methods of correcting hyperkalemia. So apart from the use of salbutamol, we could also give iron binding resins. Keazilate is something that we use. It will bind excess potassium and mop it up. So then at the extreme of situation, when you have refractory potassium, you've done all these things, it's not working, you might just have to do hemodialysis for a patient to reduce the potassium level in order not to have a fatal outcome. Next slide, please. So what is shown in this slide, another confusing slide, but just as I said, you go back to our logic, they say it's a blood film of a 8-year-old girl who presented with unconsciousness. And so what, you don't understand what they are talking about. You go to your question, they tell you the abnormality is in form of plasmodium. Okay, you understand it. You go back to the picture again and you see those ring forms. You appreciate it better. They now say diagnosis is acute leukemia. Of course, it's not likely to be acute leukemia. When you have acute leukemia, what you'll be seeing in the peripheral blood film are blast cells and not ring forms, as you can see here. So diagnosis is severe malaria. Yes, diagnosis is severe malaria. Treatment of choice is IV artesunate. Yes, treatment of choice is IV artesunate. Next slide, please. It is said that the urinalysis result of a 6-year-old boy who presented with bilateral pitting fetal edema and coke-colored urine shows glucose is negative, blood is 4 pluses, pH is 6.5, protein is 2 pluses, and nitrite is nil. The likely diagnosis is acute glomerulonephritis. Yes, this could be correct. It's likely acute glomerulonephritis. You have 4 pluses of blood and protein. So you have proteinuria and hematuria. So when you have edema, proteinuria, passage of dark colored urine, think of acute glomerulonephritis. Of course, it could be related to, we talked about the fact that group A beta hemolytic streptococcus could be a cause. And in another case, if you have insect bite or bee stings as a trigger for the manifestations of symptoms like this. So you probe for this kind of history when you are clicking your patient to establish history of occurrences like this. Chronic renal failure is the commonest complication. They are more likely to have things like congestive cardiac failure. They could have acute renal failure. Not often would they have chronic renal failure. Treatment involves bed rest. Yes, some of them we require some bed rest. So the next slide, please. Baby B is a 1-hour-old unit that weighs 5.3. The essence of the other baby is just to show the relative big size of baby B compared to a normal baby. So baby B is said to be 5.3, a big baby. So baby B is jaundice. Of course, from what you can see, you can't see jaundice. So there's a risk factor for a child having this enlarged size, a big size like this is obesity, yes, maternal obesity, gestational diabetes mellitus, yes. All these are reasons why a child may have very big birth weight like this. So, and hyperglycemia is, they are at risk of hyperglycemia. No, rather they are at risk of hypoglycemia. They are at risk of hypoglycemia. And baby B is post-date. We don't have the evidence to say that baby B is post-date. Baby B could be a 10 baby that is not post-date and still have a big size like this if the risk factors such as maternal obesity and diabetes mellitus, gestational DM are present. So next slide, please. So identify the picture is what this is telling us. What immunization is being done here? Oral polio vaccination is what is being done. Oral polio vaccination is the vaccination that is done, which is administered through the buccal cavity. For hepatitis B, it is administered as a deep IM injection. Pneumococcal vaccine is also administered as a deep IM injection. Vitamin A, maybe usually for the kind of baby we are looking at, we don't expect vitamin A to be given at this age. Vitamin A is usually given at 6 months and 9 months. So this child is looking like a newborn baby. And even though vitamin A is given orally, vitamin A is not given with a vial like this. It comes as a kind of like a soft gel, which is perforated and is emptied inside the buccal cavity and not as a vial like this. So when you see vials like this with vaccine being administered, think of oral polio vaccine. Next slide, please. So this is another picture depicting purulent or classical post-discharge from both eyes, usually related to ophthalmia neonatal, and both organisms that are shown are possible causes of this kind of manifestation, Neisseria gonorrhea and chlamydia trachomatis. So another, next slide, please. Concerning malaria parasites in Nigeria, which is most common, of course, Plasmodium falciparum is the commonest form of malaria that we have in Nigeria and many sub-Saharan African countries. Next slide, please. So, severe, concerning neonatal resuscitation, which is acceptable, severe asphyxiation is ABGA score of 4. Ambu bag with face mask, not important when apneic. 3 chest compression to 1 ventilation. If heart rate is less than 80 beats per minute, no place for IV fluid. So, telling us about neonatal resuscitation, severe asphyxia is when you have asphyxia, ABGA score of 3 and below. So, it's not 4, it's 3 and below. Ambu bag with face mask is not important. Ambu bag with face mask is not important. Yes, ambu bag with face mask is very, very important. The single most important instrument you need in neonatal resuscitation is the ambu bag. The single most, if you don't have anything, even if you don't have suction machine, if you don't have anything to suction away, it's important to have the ambu bag. Unfortunately, it is that ambu bag many centers will not have, and they will now be sanctioning a child that is not breathing. If a child is not breathing, the ideal thing to do is to start bagging the child. Breathe for the child within the first 1 minute of life. You start ventilation of the child's lungs. By the time you complete one minute, which is referred to as the golden minute, and the child is not breathing, start breathing for the child. That's not the time to be suctioning the child. Unfortunately, many people will be suctioning the airway. A child is not breathing, you are suctioning the airway. That's very wrong. So, ambu bag is very important and the single most important instrument you need in a child's resuscitation. It's 3 chest compression to 1 ventilation. Yes, 3 chest compression to 1 ventilation, and it's got a reading. Do 1, 2, 3 breathe. 1, 2, 3 breathe. So that within 2 seconds you are completing 4 events in a cycle. 4 events in a cycle within 2 seconds. That's 3 chest compressions and 1 ventilation. But usually you do the chest compression when the heart rate falls below the depicted value. No place for IV fluid. First, there is a place for IV fluid. We use IV fluid such as normal saline to expand the circulation when it is not effective, when circulation is not effective. So that's the last picture on our picture test.